Have you ever had that creepy crawly feeling deep in your legs at night? An overwhelming urge to move them that just won't quit? Well, you might be familiar with Restless Legs Syndrome, or RLS. Today, we're going to break down a major new review from the Journal of the American Medical Association that is literally changing how doctors understand and treat this surprisingly common and serious condition. So just how common are we talking? Well, take a look at this number, 3%. That's the percentage of adults in the U.S. who are dealing with RLS that's considered clinically significant. Now, what that means is their symptoms are moderate to severe, and they're happening at least twice a week. So right off the bat, we know this isn't just some rare minor annoyance. We're talking about a widespread neurological disorder that's impacting millions of people. And the impact, it goes way beyond just feeling fidgety. The research is crystal clear. RLS seriously wrecks your sleep. In fact, something like 60% of patients wake up 3 or more times every single night. But the consequences get even more stark. RLS is linked to a nearly 30% rate of cardiovascular disease and a 30% prevalence of depression. It even brings a significantly increased risk of suicidal ideation. So the main takeaway here is that this is not a minor inconvenience. It is a serious medical issue with profound consequences for both your physical and your mental health. Okay, so now that we've established the stakes, let's get right down to the basics. What exactly is restless leg syndrome? And maybe more importantly, who is most at risk? Now this is fascinating. You see how the prevalence of RLS just skyrockets in certain groups? We said about 3% of the general population is affected, but look at this, a full 50% of people going through opioid withdrawal, nearly 28% of those with multiple sclerosis, and 22% of women in their third trimester of pregnancy. This data just brilliantly illustrates that RLS is deeply tied to other physiological states, especially things involving iron deficiency and neurological stress. All right, so with such a wide range of symptoms and all these associations, how in the world do doctors actually make a definitive diagnosis? Well, it turns out the process is surprisingly straightforward. So, how is restless leg syndrome diagnosed? This is a really key question, and the answer might surprise you. The JAMA review makes it a huge point to say that RLS is a clinical diagnosis. What that means is it's based entirely on what the patient says, their history and their symptoms. There are no fancy scans, no overnight sleep studies, or polysomnography required. It all just comes down to a very specific set of criteria. And those criteria are perfectly summarized by the acronym URGED. All 5 of these have to be met. First, there has to be an urge to move the limbs. Second, the symptoms get worse during periods of rest. Third, they get better with movement, like walking around. Fourth, they have an evening or nighttime onset, which is classic for RLS. And finally, a differential diagnosis, meaning other conditions that could mimic the symptoms, has been ruled out. It's a simple but really powerful tool based entirely on listening to the patient's story. Okay, this is where the story gets really interesting. The guidelines for treating RLS have gone through a massive shift, moving away from a class of drugs that's been used for years, and it's all because of a serious, hidden risk. You see, for years, the go-to medications for RLS were a class of drugs called dopamine agonists, and they worked. But a really troubling paradox started to emerge. The very treatment that was designed to relieve the symptoms could, over time, actually make the condition much, much worse. And this phenomenon has a very specific name. It's called augmentation, and as you can see, it's an iatrogenic, which is just a medical term for medically induced worsening of RLS. When augmentation happens, symptoms start showing up earlier in the day, they become way more intense, and they can even spread from the legs to the arms. The treatment itself becomes the cause of a more severe form of the disease. And we're not talking about a rare side effect here. According to the research, the annual incidence rate of augmentation for patients taking these dopamine agonists is between 7 and 10%. That is a significant risk, and it is the single biggest reason that the entire treatment paradigm for RLS has been completely flipped on its head. So, if the old standard is out, what's taken its place? Let's take a look at the new, evidence-based first-line therapy that completely avoids that risk of augmentation. This slide lays out the shift perfectly. On the left, you've got the dopamine agonists. They are no longer recommended as the first choice for daily therapy because of that augmentation risk and also a risk of impulse control disorders. And on the right, you have the new standard of care, Gabapentinoids. Drugs like gabapentin and pregabalin are now the first choice because they work well, and crucially, they do not cause augmentation. So the modern approach really rests on these 2 pillars, and I want you to notice the order here.
The very first step, before you even think about a daily medication, is to check the patient's iron status. If their serum ferritin level is at or below 100, iron supplementation is the guideline-recommended first treatment. It's only if symptoms persist after that you'd start first-line drug therapy with the gabapentinoids.
So, just to recap the treatment options as they stand today, gabapentinoids are the clear first choice. Dopamine agonists have been effectively demoted. They're not recommended for initial daily therapy because of those huge long-term risks. And then for very severe treatment-resistant cases, low-dose opioids are considered a second or even third-line option.
All right, we've covered a lot of ground here, from diagnosis all the way to a complete reversal in treatment strategy. So let's boil all of this down to the most important take-home messages from this landmark review.
If you remember anything from this breakdown, make it these 5 points. 1. RLS is a common and serious disorder. 2. The diagnosis is clinical. Just remember the URGED acronym. 3. Always check iron first. This is a non-negotiable first step. 4. The treatment game has changed. We've shifted away from dopamine agonists because of that risk of augmentation. And 5. Gabapentinoids are the new first-line drug therapy. I think this quote from the discussion around the paper just perfectly captures the essence of this whole new approach. They call it a de-dopaminergization shift. It's really about being smarter, prioritizing a patient's iron status, and choosing safer long-term options to avoid medically induced harm and to truly finally improve their quality of life.
And that really leaves us with one final crucial question. For patients and clinicians alike, is your treatment plan for restless leg syndrome up to date with this new medical consensus? Based on all this new evidence, it's definitely a conversation worth having.